short session, Angiography and Embolization for Hemorrhage Control. Attendees will remain in listen-only mode. Comments and/or questions can be made using the chat or Q&A function. Today's session is being recorded and will be available within 1 week on our Trauma Registry Association of Missouri YouTube channel. Details for that will be sent out along with a PDF of today's presentation, which will be emailed to all attendees at the end of the session today. Now that we have that housekeeping out of the way, today we will join Kathleen Ruckdeschel in her webinar that is geared to provide education on ICD-10-CM and PCS codes. She will review with us CTA and interventional radiology, angiography, and embolization coding. Additional review of TQIP process measures for angiography will also be included. Kathleen currently works for Parallon HCA Healthcare, where she is the team lead for clinical data and registry abstraction. She holds a bachelor's in science for nursing RN license, along with the CEN, CSTR, and CAISS certifications. Thank you so much, Kathleen, for preparing today's educational session for us. And with that, I will turn it over to you.
Thank you for the introduction. My name again is Kathleen Ruckdeschel. I just wanted to share a little bit more about myself. I have over 25 years of ER trauma nurse experience and fell in love with trauma registry when I started a level 3 trauma center in the Kansas City area. At that time, I didn't have the trauma registry experience, but I knew that was what I wanted to do more moving forward. So in 2016, I landed a trauma registry job at a level 1 facility and was able to lead them to ACS certification with my registry data. Today, as Amanda said, I am the team lead of 25 registrars that work at level 1, 2, and level 3 facilities. This topic came to light about 1.5 years ago when I was doing some data drill downs and performing some validations. And I found that there were some education opportunities when I noticed that the registrars were coding CTAs as fluoroscopies or vice versa, and also incorrectly reporting CTAs to angiogram. We also found some gaps in our coding of the fluoroscopy and embolization procedures and reporting those procedures to TQIP.
Kathleen, I just want to interrupt you just briefly. Everyone, we know that you're not seeing her presentation yet. She is just introducing herself. She will share her screen here in just a moment, and you should be able to then see the presentation on the screen. We had people in a panic.
Well, thank you for telling me that. I think we had it shared and it may have disappeared. All right, are you seeing it?
Let me check that chat function. Okay, I can see her. Yes, they are seeing your screen. We are clear to move forward.
All right, here we go, guys. We got it. All right, so we will be using Slido today. If any of you have never used Slido before, you can access this on the Slido website and sign in using the passcode, or you can simply scan that barcode using your phone or your iPad or any smartphone device that you have handy. And the passcode will be the TMOCYH. It is not the 3103560. I promise you that will not work, as I have tried it several times myself. So we'll give you guys a few minutes to get that done, and then you'll have an opportunity to do that again later. That code will come up again.
A few people saying they don't see the QR code.
Are you seeing it?
I am able to see it, but they are not able to see the Slido. I only see the presenter. Give me just one moment. I only see the presenter. I am able to see the screen. I see the code. So there are some people who are able to see the code and others who are saying they cannot. You will need to, under your view, change your view to full screen for your webinar. To see if that helps. Give everyone just a moment to get that done. We do not have that option. Somebody else says that worked. I'm in full screen and still only see the presenter.
It isn't anything on my end, is it?
I don't think so. Because we have some who are able to see and some who are not. So I think it is on the presentation or the view that they have. Let me change. Are you able to see now? Let me go back to the chat. I can see both. I can see both. I can see Slido. We have Amy saying no. In full screen, only see presenter as well. Presenter, direct link. So they're saying when they switch to the prior link, they're able to see the full QR code and everything, but the direct link is not letting them see the PowerPoint. Yes, use the original link and it worked. So they're saying if you go back to the original link, that they had success with it working. I am not sure with this technology why it would not let anyone see. Could you try sharing your screen? Stop share, Kathleen, and then reshare.
And reshare, yeah, we can give that a shot. Let me try entire screen. Let's try that and see if that does it.
All right.
It was me.
Got it. We've got it.
Live and you learn.
We have a lot of got it.
Sweet.
Thank you. Yes, that worked.
So for future reference, do what was it called again? It was called
full screen.
Hold on. It was called full screen.
Yeah. And I guess it probably was great that we had this little hiccup at the beginning because we still have people who are joining.
Entire screen is the one you want.
All right.
And you can still see me, right?
I can see you. I'm not seeing the presentation yet, but
now I've broken it.
Let me go back and just make sure. Is everyone still good? Nope, now it's gone. Try that one more time, Kathleen.
There we go. Okay. Technology is fun. All right. Does anybody need any more time to get that Slido code in?
I see you now. I got it. Everybody's got it. The Slido code. The Slido code. I will let Kathleen just tell you that number and the passcode in case you need that. I'm going to mute now, Kathleen.
Okay. All right. So once again, that passcode TMOCYH. Well, now my PowerPoint is a little locked up. There we go. Okay, so first slide. What is a CTA? This is a computerized tomography of the arteries. So as the name implies, this is going to occur in the CT or the CAT scan suite and is frequently done along with all your other CTs that are ordered on the patient. There are times where they might do the initial set of CTs and then they'll go back an hour later and decide they want to do the CTA based on something that they found on those original CT trauma scans. These are performed by a radiology technician. They do not need a provider or a physician at the bedside to perform these scans. And this is used to identify any blockages or disruptions that are in the artery, but it can't fix it. So these CTAs are diagnostic only. We can't fix anything when we do the CTA. It actually visualizes the inside of that lumen or the blood vessel. The CT angios were actually introduced in the early 1990s with the introduction of the helical or the spiral CT scans. Before that time, if any of you were in the healthcare before the 90s, those old CT scans were very slow. It took a long time to run the scans, approximately a half an hour, 45 minutes to get all your trauma scans done. So they weren't as readily used. So once we got the spiral and helical scans in place, this became more commonplace that we took our trauma patients to CT scan more often versus the OR or the IR suite. These are once again performed fairly early in the patient's trauma workup, and they're frequently performed on patients that have a first rib fracture, a clavicle fracture, or those severe extremity fractures where you might have a concurrent injury to that vascular system. CTA is diagnostic. It gives us that insight toward the need to move forward with interventional angiography. You might also have a CT abdomen and pelvis are performed to rule out those injuries of the thoracic or the iliac vessels. And then we want to look at our coding. Here are some ICD code examples for CTA. The head, we might have a B32R and 1 or Y. So 1 is for your low osmolar, and then the Y is for the contrast not specified. But the 3 is your upper arteries, and the 2 is the CT, and then the R here, that is our what artery it is, which would be the cerebral arteries. Here's an example of the CTA of the aorta, and then our bilateral lower legs. So what is IR? How is that different from a CTA? These are performed in a radiology suite. So the patient is actually going to go for kind of a surgical procedure, but they're usually done in a special interventional radiology suite, or some hospitals may just send them to a special procedures lab, and others may actually send them to their cath lab to have these studies done. So the location may vary, but the procedure is going to be essentially the same. In these cases, you need to have a radiology specialist, or sometimes a vascular surgeon may do these in an OR hybrid suite, but you are going to have that physician performing this exam or this procedure. A flexible catheter is guided through a puncture of the artery, usually the femoral, and then they use a dye that is released through the catheter, and then they view this on a fluoroscopy that shows them what's going on in that vessel in real time. This procedure can diagnose and fix the artery at the same time. So there are a few times where it is kind of a diagnostic test that they do this for. Interventional radiology has been around a long time. It was first conceived in 1964. So this is not a new procedure and was pretty much the gold standard anytime we had vascular issues before the advent of that CTA that would tell us less invasively what was going on with our patient. Stent grafting was then developed in the 1980s, and then coils followed in the early 1990s. I was a pretty new nurse in the early 90s, so I remember seeing the coils as brand new technology. I got to sit in on a couple of those in nursing school. So it was very interesting, and it's been interesting through my career to watch these advancements in medicine. Some facilities, and you can do these for your upper artery or lower artery. If they're just doing the fluoroscopy, you're going to code it to the fluoroscopy or the radiology exam. So that I'll start with B, the 3 is the upper artery, the 4 is the lower, and then the 1 is your fluoroscopy. There's a couple different approaches we can use with fluoroscopy and angiography. The most common is going to be your percutaneous, and this is entry by puncture or minor incision of instrumentation through the skin or mucous membranes and other body layers necessary to reach the site of the procedure. So they're going percutaneously into that vessel to reach the site, and then we have the fluoroscopy that's helping us see where it's going. In contrast, we have our percutaneous endoscopic. This is also done through a minor incision, but we have some kind of instrumentation that is helping us reach and visualize the site of the procedure. And this is usually done through an endoscope, which is a long thin tube with a small camera inside. I don't think I've ever seen an angio done with the endoscopic approach, but I wouldn't say that it doesn't occur in some places. So what is angiogram with embolization? So embolization means they're basically going in and they are causing a clot or a blockage of that vessel. And what that is going to do, the vessel is bleeding, so they want to go in there and they want to stop the blood from pouring out that vessel so we can save that patient's life. There's a lot of different devices out there that we can use to do this. We have coils, and that little picture right here, this is a picture of our coils. So it's just what it is. They put the tube in and then they push these little coils out through the bottom of the tube. And in the one picture, you can see it going into this little outpouching. This is what we call a pseudoaneurysm. I'm sure some of you have seen that word used in charts. So that is a pseudoaneurysm, and they basically just filled that up and blocked that off. So there's no blood getting in there that can cause that little pseudoaneurysm to blow up and bleed out into your patient. And then this picture right here just shows where they are putting that coil into the lumen of the vessel. Those are generally used more distally, and they're going to block off that bleeding. So when you have that spleen that's bleeding out, they go into that bleeding vessel, they pop that coil in there, and that occludes that bleeding from going any further. Implants or plugs, those are fairly new. I tried to do some research on when they came about, but it looks like they came around 2020, 2021. So they are super new on the market, and I looked in 3M and their definitions, and I do not see them listed on their intraluminal devices, but I promise you that they are a type of intraluminal device, and I'm starting to see those more and more often as the choice for doing these embolizations. Another one they might use is gel foam or glue. These are actually temporarily block off that artery. Gel foam it's a little dressing. It's used in several applications in medicine. It can be put on like a bleeding fingertip. We have patients that avulse the end of their fingertip. You can pop a piece of gel foam on there and it kind of absorbs that bleeding and clots it off. So gel foam can do the same thing in your vessel. The same technique, they feed it through that little wire they put in there, and they pop out these little what we call pledgets or pieces of it. They kind of expand in the vessel and they block it off. But what happens later is the vessel has time to heal, and then these little pieces of gel foam just kind of disintegrate and reabsorb into the system. So there's nothing blocking the vessel anymore, and you have a nice healed artery. So how do I code these? These are generally coded as either an occlusion or a restriction. Sometimes it's kind of hard to figure out which to pick, right? You're like, well, which is it? Is it an occlusion or a restriction? So we really struggle with that. So with my large group of registrars and the help of Amanda, and we sat down, talked about it, I pulled in all my information, and the general consensus is you read through the report and you find out, was there blood flow past that device or that gel foam that they put in? So if there is no blood flow, it's occluded, right? There's nothing getting past it. If there is blood flow, it's just restricted. We've slowed down that blood flow. It's a little restricted. So in the case of the pseudoaneurysm, you're going to have blood flow past that, right? So that's probably going to be a restriction if you read through your report. But if we do this gel foam here, that's pretty full. That looks more like an occlusion. But we'll get to that a little bit more later. I have another slide that talks about our lovely gel foam. Angiogram with stenting. So a stent is a small wire mesh tube. It's implanted to strengthen a weak artery or block a false lumen of a pseudoaneurysm. So we've used our coils for pseudoaneurysms. We can also use our stent graft for those. It can also kind of be used to block off that little tear in the lumen of the vessel. So this can be occlusion or restriction. Again, we have to read through that wording and find out if there's that blood flow. So I have a couple examples here. The occlusion of the splenic artery with a stent. There's some blood flow. And I mixed those up, guys. I will fix that slide. So no blood flow past the stent will be your occlusion, and restriction will be some blood flow past the stent. And again, these can be performed percutaneous endoscopic or percutaneously. So read through your report and find out what it is. And as always, if you have questions, phone a friend, ask someone who's been there, done that, and we can help you figure that out. So how do we abstract this data? We've figured it all out, right? We figured out what happened to our patient. They had their CTA, they went to IR, they got some blood. Now what do we do with all this information? So the procedures are required to be coded as ICD-10 procedures per our NTS Data Standard Dictionary. And we also have to think about what codes are going to go to our TQIP sets. So when splenic procedures are present, I always kind of pop in and just look at my splenic codes and kind of see, well, is this one of these splenic codes, right? I like to compare it and see what I have. And then I like to go back and see, well, is that really what it is? If I don't have this code, should it meet that code? So I'll dig a little deeper and see if I should be including one of those TQIP code sets. And for most of you, a lot of you may not be familiar with the TQIP code sets. I sure wasn't when I started as a brand new registrar, and I started hearing about them at ATS webinars, and I was like, oh my gosh, what is a TQIP code set? What is this? Where do I find it? So finally found out that it comes with your TQIP benchmark report for your facility. So if you don't have that handy, talk to your trauma program managers, ask them to go into that TQIP benchmark report and pull those codes for you so you have it. I promise you there's all sorts of great information in those TQIP code sets beyond just the splenic coding. Of note, and how we grow as registrars, we also found out that we'd been using the wrong code for our ICP monitors. So that was a big change of practice after we got those codes. So always a good thing to review those. And then they change every time they send a TQIP benchmark report out. So you should be replacing those every time you get that benchmark report. And what else we're going to do? We're going to abstract our TQIP process measures for angiography. So every time we have that angiography, we have to think, will this need to be collected in my TQIP data set? And how do we know? Well, first of all, we're going to open our dictionary and take a look at it and read those process measures and see if it does or not. In summary of that, though, if the patient received whole blood or PRBCs in the first 4 hours after hospital arrival, the fields for angiography must be completed. If the patient receives IR radiology only, code the fluoroscopy of the vessel for ICD-10 coding, and if embolization is performed, code the embolization. There is no need to code that fluoroscopy in addition when you've coded that embolization or that stent placement in that vessel. So this is our first angiography process measure. If any of you want to follow along in your data dictionaries, and you might just want to keep it open because we're going to have a Slido quiz later on this, it is page 162 in your dictionary. And that's the 2023 version. Of note, always make sure you have the right year with the right data that you are validating or working on. So even though we're in 2023, if you've gone back to look at a 2022 patient or a 2021 patient, make sure you pull that right dictionary to go with that data set because they do change slightly through the years. All right, so our first process measure is our angiography. We're going to report this on all patients with transfused packed red blood cells or whole blood within the first 4 hours after ED hospital arrival. They want to know the first interventional angiogram for hemorrhage control within the first 24 hours of ED hospital arrival. So they want that first IR visit. Element values, we would report none if no angiography is done. Angiogram only, that's only if they go in there and take a look and do that fluoroscopy. And they have this in the dictionary that this does not include CTA. We have angiogram with embolization, and then we also have angiogram with stenting. So you need to make sure you know what kind of device we put in the patient. You'll only report angiogram with stenting if stenting was performed specifically for the hemorrhage control. And there are times where you might have to reach out to your trauma program manager or your trauma medical director or your facility to determine if the angiogram were performed for hemorrhage control. And then we're going to report the null value not applicable if the patient did not meet the reporting criterion. And that would be if they did not receive that blood in the first 4 hours. The second process measure is the embolization site. They want to know what site was embolized. Someone was asking what page 162 and 2023 is where those process measures start. Embolization site process measures report on all patients again with the PRBCs or whole blood within the first 4 hours. They want to know the organ or site of embolization for the hemorrhage control. There were some changes. I believe it was this year they added the peripheral vascular neck extremities. Is that right, Amanda? Was that this year we changed that, right?
Yes.
They all run together, which is why I have to pull the old dictionaries out because I can't keep track of it.
Yeah.
So they did add the peripheral vascular neck and extremities. There's been a lot of attention on blunt cerebral vascular injuries recently of the neck. So that has kind of become a hot topic in most facilities. So I'm sure TQIP has picked up on that and added that as a option for that. So we're going to report NA if angiography is none, angiogram only, or angiogram with stenting. So stenting is not considered an embolization. And then you would report all values that apply. So you might have a patient who comes in and they find out that, oh, I needed to do the pelvic, the iliac, but then they also found that there was a vessel to the kidneys bleeding, so they embolized that as well. So it is possible to have more than one response here with the same embolization. And I also wanted to take note that 7 is missing on there. We have 1, 2, 3, 4, 5, 6, and then 7's missing. I didn't forget anything. They have changed this. They've retired some data elements. So instead of reassigning a data element to that number, they just drop it off and then keep counting and assign a new value. Angiography date time process measures. This again is reported on all patients with transfused packed reds or whole blood within the first 4 hours of ED hospital arrival. The date time of the first angiogram with or without embolization was performed. So they want stents and everything for your date and time. And then you're going to report the null value not applicable is reported if the data element angio is the element value none. So if they didn't do any angio, you would report none. And then report not applicable if the patient did not receive that packed reds or whole blood. And then very important, highlight this, write it in your book. Procedure start date time is the date the needle insertion in the groin. So be sure that we don't want the time they got to IR, we want the time that they poked that needle through the skin. If you are having troubles finding that in your EMR, you need to reach out to someone. You should have a champion or someone at your facilities that can help you locate where that is in your med record. If it isn't documented at all, you find out, oh my gosh, no one's documented then that is a PI issue, and that needs to be taken up with your radiology department to make sure that someone is documenting that needle time somewhere in your medical record. I found that most facilities and radiologists are pretty good about documenting that needle time. Okay, and that brings us some case studies. So now we get to use our Slido. Yay! Okay, so case study number 1. We have Mr. Jones. He's 24 years old, and he was a restrained driver of an MBC on 1/1 at 0100. He must have been out late on New Year's. He was restrained with a lap belt only. On 1/1/2023 at 0200, he arrives to your ER with complaints of low back pain. And as registrars, we know that lap belt only, he's probably going to have some injuries there, right? Because he bent over that seat belt and it caused some torque to his spine and probably his abdominal organs. So on arrival, his BP is 84/42. His heart rate's 104, respiratory rate of 18, SpO2 99%, and they got him on some oxygen. They decide to give him 1 unit of packed red blood cells, and his blood pressure increases to 104/62, and his heart rate comes down a little bit to 92. They take him to CT, and they find a grade 3 spleen laceration and a T11 chance fracture. His vital signs remain stable. They decide to manage him non-surgically. His stay is pretty non-eventful until the morning of 1/2/2023 at 0500, when he gets up to the bathroom and he has a syncopal episode. Once back to bed, his BP is a little low, 100/62. So they make the decision to take him down for a CTA of his belly. And they notice that he has some extravasation or bleeding from his spleen. The start time for the CTA is 04:45. So they notify the IR team, and they take him emergently for splenic embolization. He arrives in the IR at 1/2 at 0600. Needle time is 06:15. An 8mm implanter plug was deployed in the proximal splenic artery under fluoroscopy. And documentation supports lack of blood flow past the plug. All right, question number 1. Which ICD-10 procedure would be appropriate to report for the CTA of the abdomen? And somebody give me a thumbs up if the Slido is working. Sometimes it gets a little stubborn. Looks like it's going on my end.
Yep, I'm seeing some thumbs up on this end.
Yep. So I'd say this is like watching popcorn pop. How many signed into the class?
We have 214 attendees.
Okay.
I do see some hands raised. We will get to all questions at the end of the presentation.
They may have been telling me their Slido was working. The code is TMOCYH to get into Slido. So they had a CTA of the abdomen pelvis, is what was ordered. If I move off the Slido, it will stop it. And about 111 responses. Like popcorn popping.
Yes, it is. We may have had some who didn't catch all the details and are just now trying to get logged into that.
So again, the study that was completed was a CTA of the abdomen and pelvis.
We have a few, Kathleen, who are saying they're not able to put the answers in.
Give it a second. It might be a little overloaded. I think Slido can be a little touchy if a lot of responses are going in. When you sign into your Slido with the code, it should come up after you scan that barcode and sign in. It should come up and let you answer. So thank you, whoever said to go over the polls tab. All right. For time's sake, I'm going to go ahead and move on. We have about 140 people in. So we have 73% of people said CT of abdominal aorta with low osmolar contrast, which is what I would go with as well. The CT of the abdomen pelvis would just be a straight CT and would not be directly visualizing the CT, the abdominal aorta and the vessels. This is a little tricky because there's not a great code for the CTA of your splenic arteries. That's not an option. So sometimes as registrars, we end up choosing the best code to describe what happened to the patient. And always remember, we are coding for registry and we're not coding for billing. So it wouldn't affect billing. We just want to be able to capture that into our registry. So general consensus of registrars across the land would be to code that to a CTA of the abdominal aorta. And of note, which I didn't mention, CTAs or CT angios are always done with contrast. You can't do a CT angio without contrast. Next question. What ICD code would we use for the implantar plug placed in the splenic artery? And to refresh everybody's memory, there was no blood flow after that implantar plug was placed. I should have had music.
I know, I was just thinking, I feel
Can
like
you
we
sing
need
for
to
us,
be
Amanda?
singing. Isn't that the Jeopardy thing?
It is Jeopardy theme.
Something like that.
I get to be Alex today. Alex passed away.
It's like a race to see who can guess correctly the quickest, can get their answers submitted the fastest.
We'll never know. We'll never know who submitted the fastest, so it doesn't tell me that.
I always like when I answer these, I'm like watching to see the number increase. I'm like, yep, that's my number. That's me.
I know.
I'm number whichever. Yeah. Thanks everyone for participating. Like she said, we don't know who guessed the correct number item and who did not, but it's just great to kind of test your knowledge and give you a chance to gauge yourself, almost like if you were studying for the CSTR exam. You're writing these things and you're testing yourself against what you've already written down in your study guides. And then it helps us to show engagement with the ATS, who so kindly approved these sessions for your CSTR CEUs and your registry required CEUs.
I think we're starting to slow down here. We'll do the review. And we realize also not everybody, this isn't everybody's thing. Ding, ding, ding. Awesome, guys. So yes, occlusion of splenic artery percutaneous with intraluminal device. So we wouldn't go with the endoscopic code because the tube or the little wire they put in isn't actually an endoscopic device. They watch it on fluoroscopy. And this is actually a common thing that I've seen registrars do. Don't feel bad, and your code's still going to be okay. But endoscopic, they kind of have a tube that goes in and they're looking in it and watching what's going on. Like when they do your colonoscopy, they put that tube up there and they look at a little camera and they see what's going on up there in your rectum. Same thing with your XLAPs, your belly. Sometimes they use that little tube that goes in and they look on the scope where they're going. This is different because the tube goes in and they watch where it goes on that fluoroscopy. So that's what makes this different from the endoscopic. And then everybody got occlusion of the vessel. So that's awesome. All right, and next one. Sorry, guys. Let me go back. We are going to have a little drunken Slido today, just FYI. All right, and on to case study 2. Mr. Johnson is a 32-year-old female kicked in the abdomen by a horse. She arrived ambulatory to your ER on 1/18/23 at 1200. Her vital signs at triage were 90/40, heart rate 102, and respiratory rate 22. She was activated as a level 1 trauma. She was taken to CT and noted to have a grade 4 liver laceration with active bleeding. IR was notified and she arrived in IR at 13:15. Needle time was 13:40. At 13:55, her blood pressure drops to 74/40 with a heart rate of 116. She received 2 units of packed reds and 2 units of FFP. And at 14:15, the site of bleeding was identified and the gel foam embolization of the hepatic artery was performed. There is no blood flow past the embolization. First question, which code would we use for the gel foam embolization of the hepatic artery? We have occlusion of the lower artery, percutaneous no device, occlusion of the hepatic artery, percutaneous interluminal device, fluoroscopy of the hepatic artery, or restriction of the hepatic artery. This is our tricky one. Amanda, are we a hard stop at noon?
No, we are not. People may need to jump off. I know we
Okay.
had a little bit of a hiccup, so we can go a little over. People may need to jump off. If they do, they'll have the recording to review.
Okay. And I can cut these a little shorter. I know everyone really wants to get their answer in, though. Let's go ahead. Okay, so 63% got that occlusion of the hepatic artery percutaneous interluminal device. A lot of people said restriction, which is a common practice in registry world. So as we were searching this, and the no device was common practice, as we were searching for information and working on this, we use 3M for our ICD-10 coding, and they have these little coding clinics on there. So, and I think I was looking for something else at the time, and I found one on there that talked about gel foam use. And it actually says that to use inclusion and to use the intraluminal device, the rationale is that it's cut into those little pledgets. So those little pledgets they cut that gel foam into is considered a device, even though it dissolves and goes away. But those of you that did restriction of hepatic artery with no device, this is common practice that we found in the registry world. No need to go back and change anything or stress out over it. We've still captured that hepatic artery. So then moving forward, we change our practice. What would be reported for first angiography for hemorrhage control for the embolization with the gel foam? And again, we had that angiogram, and they deployed that gel foam into the vessel. And that stopped the bleeding. Another great thing about these Slidos is we can identify any education gaps that may still exist or that are out there, and these can actually help drive our future education.
Yes, it does. This has been wonderful. Thank you so much for putting this together. I love the format that you used.
The Slido is a fun tool. It takes a little practice. So 95% angiogram with embolization, because that gel foam that completely blocked off that vessel, so they embolized it. For a few people that put the stent, the stents, they are going to say stent very clearly in that documentation. I've never seen it not be clear that they were using a stent. What organ site would we report for angiography with hemorrhage control? Got 102 responses. And remember, this patient did receive that blood within the first 4 hours, even though they did receive that in the IR suite. So it doesn't matter where they got that blood as long as it was in the first 4 hours. They could even get it after they got their IR all done, and then they go to ICU and they end up getting a unit of blood. And you would still count this angiogram even though it occurred before they got the blood. All right, we got most responses in. And there we have liver. It was the hepatic, so we'd mark that for liver. So when you're looking at those vessels, think about what vessels. I know they say organ, and then we say hepatic for the vessels, but then we say it was the liver that was bleeding. So we want to look at those vessels that are leading to that organ. So the hepatic vessels go to the liver, so we choose liver in that case. And which date and time should be reported for angiography for hemorrhage control? I have some times on there to refresh your memory. The patient arrived in IRR at 13:15. Needle time was 13:40. 13:55, the blood pressure dropped and they got their blood. And at 14:15, the site of bleeding was identified. And they got the gel foam in there. Review your definition if you need to. I highlighted this earlier on my slide. Hint, hint, hint.
Say it's not a hard stop. It's given me a 5-minute warning.
Oh, okay. I can't imagine that it wouldn't let us go on.
Right.
And yeah, someone was mentioning that the case studies would be nice to have up there. This can be kind of cumbersome to put the case study up there as well. I played with that and it wasn't working out too good. We'll go ahead and move forward since we're running short on time. So 1340, that is our needle time. Remember, we want that needle time. Case study 3, we have a 54-year-old male involved in an MVC. He arrives, his vitals are stable, arrived at 1700. CT showed a lateral compression fracture of his pelvis with a pelvic blush. Despite a stable vital signs, they decided to take him to IR for evaluation of bleeding and possible embolization. He arrives at 1900, needle time is at 1930, and at 1945 his blood pressure drops and he gets a unit of blood. They didn't notice any active bleeding, so there was no embolization or stenting required. So just to help you guys with the questions, we have arrival at 1700. 2 hours later, he went to IR and he did get the blood within the first 4 hours after hospital arrival. And they went in and they did a fluoroscopy, looked for bleeding, didn't find any, so they didn't do any embolization. So question 1, which code would we assign to the angiogram of the iliac arteries? And hint was we just went in and looked around.
I extended to 12:30 in the meeting event, and I have some people in the chat saying it usually doesn't stop.
Okay, so good.
We'll cross our fingers.
We're pretty close, so. All right. So, yes, fluoroscopy of the pelvic arteries with contrast. So this is a common thing I've seen as well. And actually, this is when I started as a registrar, I chose this inspection of the lower artery percutaneous because they were going in there and looking around, right? Makes sense. So, but general registry practice is to code that to the fluoroscopy for the angiogram. And I believe there's also definitions supporting that in the ICD-10 coding classes as well. But I can completely understand where this inspection of the lower artery percutaneous would be chosen. That was one of the codes I used. So then we grow and we learn as registrars. All right, what would be reported for first angiography for hemorrhage control? We have angiogram only, angiogram with embolization, not applicable, or none. Remember, we went in there, they just looked around. They did get blood within that first 4 hours. About 110 responses there. We'll go ahead. And that is indeed angiogram only, because all we did was look around. We didn't get in there. We didn't do anything. We just looked. So that's going to be your angiogram only. We wouldn't do not applicable because the patient did get the blood, so they meet that process measure to report it. And then what organ site would be reported for angiography hemorrhage control? You guys might want to pull your dictionary out on this one. I think I double checked this one 3 times to make sure I had the right answer. And you guys, even registrars who've been doing this their whole life, they still pull out this dictionary and read it almost every time they abstract these fields. These are low volume procedures. You forget from one procedure to another. It's not like coding your hip fracture, which you've done a billion times and you probably have all those fixation codes memorized. These don't happen a lot. And a lot of facilities, level 3s, some level 2s don't even do these procedures. They're going to transfer these patients out. And even level 1s, you may only have one of these in a blue moon. Yeah. If my background wasn't blurred, you could see my data dictionary, my AIS book open behind me.
Yeah, I have mine on a shelf right behind me as well.
So I always tell people, use your resources, and then if you still can't find the answer, reach out to someone who would know it.
Yeah.
All right. This one is going to be not applicable because we didn't do any hemorrhage control. They just popped in there and looked around. So it will be not applicable. So under your additional information in the dictionary, it says the null value not applicable is reported if angiography element value is none, angiogram only or angiogram with stenting. So always read that definition and always read that additional information, because they always have other little tidbits hidden in there that's going to change your mind after you read that definition at the top. Next one, what date time should be reported for angiography with hemorrhage control? Patient arrives at to IR at 1900. Needle time is 1930. And remember, we did that response earlier and said they were just an angiogram only. So these last two are kind of tricky. Responses are slowing down. So this one as well is going to be not applicable, because under that additional information in your dictionary, it states the null value not applicable is reported if angiography is element value is none, angiogram only, or angiogram with stenting. All right. This is my favorite quote. The secret of getting ahead is getting started. That's usually the hardest part when you jump into any project. And then, do I have any questions?
I will look. It shows 1930 is correct on that last slide.
Did I show 1930 correct? Well, that would be incorrect. It is not applicable.
All righty. Okay. Okay, that was a typo. Thank you so much. Let me look and see if there are any questions. I don't see anything all right, Q&A for CTA, abdomen and pelvis. Would you only use one code for multiple if they mention multiple arteries in radiology report? For example, your abdominal aorta, your celiac artery, your superior mesenteric artery.
That's a great question. So I'll tell you, most facilities will opt to the vessels of the most concern if those are the most concerning. So, you know, they're going to mention them all, but they're really worried about those iliac arteries. So most general practice is to code to those iliacs if we're worried about the iliacs bleeding, or that's where they found the bleeding. Do you have a different practice you use, Amanda?
I was just going to say, pretty much, I'll reiterate what you said, that common practice is different for each facility. Some will only code to the arteries where there is actually an injury. Others will code all of the vessels that were viewed in the radiology report. So I would say you need to get with your facility and determine what your practice is going to be and get that for sure put into your facility data dictionary for ICD-10 procedure coding. Of course, you're going to code for whichever arteries are looked at, but we are more trauma registry professional coding. We're not coding for billing, so it's done a little different.
And I said the most important thing is to be able to capture that it was done and that we can capture that on reporting. CTA next are the same things. We have 3 sets of arteries that you can code there. You have the vertebrals, the internal carotids, and the external carotids. So some facilities may just opt and do the carotids or that vessel that was injured. Some facilities do all 3.
It looks like that was the only thing from the Q&A. And then we have one more. I thought, what about CTA of the chest? So
chest, you're going to have generally your thoracic aorta is probably one of the most common. We code that too. There are CTAs that are done to rule out pulmonary emboli, and those are generally coded to your pulmonary arteries because that's where the pulmonary emboli live, if they have them. And I've always done bilateral on those.
there's a request to review the final question on 1930 and the data dictionary. We will get to that. We will make sure that we review that request before we send out the PDF, and any changes that need to be made to any of the slides. Kathleen will have a time to do that. Those will be sent out after today's. And then there's a question about CTA, angio, upper extremities. I look at the vessels.
The upper extremities, our favorite.
Yeah, they look at the vessels on the scan and can't find something appropriate. They even try tracing it back to other vessels. What is everyone using, and is it with or without embolization?
We do CT with contrast.
Yeah. Yes.
A regular CT with contrast because there is no code for CTA of the vessels of the arm.
Correct.
Yep.
Yeah. Yep. And that has been the coding advice given by the AHA in their coding clinics, is to use that with the low osmolar contrast, like Kathleen is saying, and then to that body region if you don't have the vessels, that you can code that out to. All right.
I'm looking up. My original answer may have been right on this.
There's some others saying no. It is with or without embolization. The additional information you quoted is only listed for embolization site. It's different for the date and time. So I think they're going back and forth. Yeah,
I believe it is the 1930. So my apologies, which is why you always read your data dictionary.
Yes.
Which I didn't do while I was talking to you guys, and it gets you in trouble.
Yes, this is great to have a conversation about all these codes here, getting advice. And that's what these presentations are all about. You know, as a presenter myself, sometimes you put things together and then you misread it and you're like, what did I do that right? And we try to bounce off of each other, but yes, it is a difficult thing putting together this information, and we appreciate all the feedback. Again, we will be working to look at those slides and get the feedback with that. We are at about 10 minutes after. I want to give a great big thank you so much to Kathleen for all of her work and putting together this presentation. I loved the format, and I hope that each of you who joined today will register and join us for next month's Lunch and Learn series session as well. And we will get to you the information on the CEUs, how to get your CEUs for ATS, CSTR if you need those, as well as information on our Trauma Registry Association of Missouri YouTube channel and the PDFs once we get all of the information updated. So with that, we will end today's session, and I thank you all, and we will see you next time.
Thank you, Amanda. I appreciate the opportunity, and I want to thank everyone for attending today. You guys have been awesome.
Thanks, Kathleen. Have a good day, everyone.
All right, bye. Do you need me to stay on?